Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole here with Tanner, and today we want to continue our pharmacy discussion, and we want to move into cardiac medications and cardiac drugs. And really, this is going to be a plethora of information. First of all, we're going to really run through a lot of information through this talk. We're going to first start, though, before we can get into the actual medications and the pharmacological responses we're going to see from the meds, we need to do a little bit of anatomy review. And so we want to talk about the adrenergic receptors and where those are at, what their roles are, et cetera. Then we'll jump into the medications themselves. We'll talk into what pressors work on what receptors, when you would want to use vasodilators, beta blockers, et cetera. And we'll end by talking about some of the pharmacological responses or treatments that we would do for hypertensive patients, both in a chronic condition and then as well as a acute condition in the OR. So it's going to be a lot. So hopefully you can stay with us here. But just to start, like I said, Tanner, do you want to bring us all back up to a review of the adrenergic receptors from an anatomical viewpoint before we actually look at the pharmacy?
This is the fun stuff for me. I think this is things that, maybe at one point made sense in your brain and maybe use these drugs every single day. And now you kind of get rusty on remembering exactly why these things work or exactly the mechanisms that are happening in our body. So for me, this is really fun to just refresh on the different receptors and exactly what's going on here. And, when we're giving these medications that we do on a daily basis in the OR. So this is the basics here. Let's talk about the different adrenergic receptors. So you have beta 1, beta 2, alpha 1, and alpha 2. So those are the four that we think of primarily, except for alpha 2. You should think fight or flight with beta 1, beta 2, and alpha 1. So these are going to be your fight or flight receptors. Think that framework in your mind. This will, make sense as we're moving forward. Alpha 1 receptors are going to use a GQ-G protein pathway. So for those who have been out of school for a long time, we're talking about these G-coupled protein receptors, and your brain is probably melting right now. You thought you only had to memorize this once, but we're bringing it back up, and we're going to go through why these medications make sense. This is going to cause contraction with this pathway being activated because you're going to have calcium, IP3, DAG is going to be released. As a result, with all of that, the alpha 1 receptors in the vascular system, when they're stimulated, we are going to see a rise in blood pressure because of constriction of blood vessels. And this will cause an increase in your systemic vascular resistance. So your alpha 1 receptors throughout the body, remember, we're causing constriction of those blood vessels. So you're going to see mydriasis. You're going to see contraction of the uterus, gastrointestinal sphincters as well. You're going to see a decrease in digestive motility. And you can also see an increase in serum glucose as well. But the main thing that we're thinking about here is this overall constriction there that's happening because of this alpha 1 receptor being stimulated. Alpha 2, again, this was the exception when we're talking about the different adrenergic receptors. When I mentioned the alpha 1, alpha 2, beta 1, beta 2, alpha 2 is going to be the outlier here. So this is the GI-G protein pathway. So this is going to be the inhibitor, GI inhibitor, and that's going to be inhibiting adenylate cyclase. So as a result, you're going to have less cyclic AMP that will be made. The main first messenger in this pathway is norepinephrine. So the effect of stimulating this receptor will depend on the location. As you're thinking, norepinephrine, initially you're probably thinking that sounds pretty excitatory. That sounds like, maybe this is going to be part of our fight or flight. And remember, alpha 2 is the outlier. This is, again, because we're activating that GI protein receptor. So that's going to be the inhibitor of the adenylate cyclase. I mentioned that it depends on the location for the alpha 2 receptors. And the reason for that here is because if the one location here is the receptor on the nerve terminal of the postganglionic neuron. So if we have norepinephrine that is being released from the nerve terminal, most of it will go across the synaptic cleft. It'll bind to the receptors on the target cell. And then some of that norepinephrine will bind to the alpha 2 receptor on the neuron and cause a negative feedback loop to occur. So it says, hey, there's enough norepinephrine that's binding to those receptors. Here's the leftover coming back. And so if that's binding on the presynaptic neuron, that means you're going to have a decrease amount of norepinephrine that's going to be released because you have that feedback loop. So as a result, we see less sympathetic response and more of a parasympathetic response because less norepinephrine is going to be binding there on the target cell. So again, this is, remember, alpha 2 inhibitory. You're still dealing with norepinephrine, but we're doing this based on the feedback loop. And so when we're stimulating that alpha 2 receptor, less norepinephrine is going to be released. And then that's where you have your decrease. Again, more of like a parasympathetic response, but we know this is still a sympathetic response. It just looks like a parasympathetic response. Another great thing about alpha 2, this is one of my favorite things about the alpha 2 receptors, is that it causes sedation. So one of my favorite drugs, Precedex, is going to be working here on the alpha 2 receptor. Clonidine as well. These are the alpha 2 agonists. So you can get sedative effects. Alpha 2 also has anti-shivering effects. You can also see some decreased insulin release. It will increase platelet aggregation. You'll see some diuresis. You can even see some vasoconstriction. And immediately you might be thinking, well, vasoconstriction, that doesn't quite make sense. Remember that there are some alpha 2 receptors in the smooth muscles on the blood vessels. So norepinephrine can bind to these receptors because it is a GI protein pathway. So cyclic AMP will be reduced, which causes more contraction in the specific cell type. So if you give a bolus of Precedex, you can see a transient increase in your blood pressure simply because of this peripheral vasoconstriction. You'll see the central alpha 2 effects immediately kick in and take over. And so overall, you'll have a decrease in blood pressure. But if you give a bolus quickly, this is why you can see that transient increase in blood pressure because of this vasoconstriction here.
So next we want to move into the beta 1 and beta 2 receptors. And so when it comes to beta, I think if we all go back to even our high school biology classes where we probably first learned about adrenergic receptors, or maybe even college, I think we were all taught you have one heart and two lungs. And that's how you remember beta 1 and beta 2. Beta 1 receptors are more prevalent at the heart, and beta 2 are going to be more focused at the lungs, as well as other places in the body, but those are the two primary spots. Now, for both beta 1 and beta 2 receptors, they use a G protein pathway. And what a G protein pathway does is it increases adenylate cyclase, and this will result in more cyclic AMP. So this is the opposite of the alpha 2 that Tanner just talked about. So by doing this, by increasing more cyclic AMP, we're going to see different responses depending on where these receptors are at. So when we're focusing on beta 1, remember beta 1 is going to be primarily at the heart. When beta 1 is stimulated, it's going to cause an increase in the heart rate and in the contractility of the heart myocardium. So think of beta 1 as the driving receptor for our heart pump. And whenever you stimulate that beta 1 receptor, you're going to have more of a forward push, if you will, from that pump, both in terms of the rate of that heart rate and then also the power and the contractility that myocardium is going to have. Now for beta 2, like I said, is mostly thought of as being the primary receptor in the lungs in the sense that it causes bronchodilation. So again, as I said before, both beta 1 and beta 2 are going to use a G protein receptor. And by stimulating this adenylate cyclase to make more cyclic AMP, what's going to happen at the beta 2 level, it's going to result in our minds thinking of a bronchodilating effect rather than the alpha 1 having a contraction effect when the alpha 1 is stimulated. So if you think about it, beta 2 receptors cause a relaxation or dilation of the bronchioles. It also can cause vasodilation as well when you see the beta 2 receptors in the vasculature. It's going to cause relaxation of your detrusor muscle, the gallbladder, the uterus. So all the opposite of what Tanner just talked about with alpha 1. And that makes sense because we're doing the exact opposite effect at that receptor when it's stimulated because it's now a G protein receptor. So in addition, beta 2 also will stimulate to cause an increase in glucose levels and insulin release. And then it causes a decrease in serum potassium levels due to more potassium leaving the circulation and moving into the cells. And so we'll get into this a little bit more, but when I used to work in the ICU, we'd have a patient that had an increased potassium level. One of the ways that we would help to reduce that would be to give albuterol treatments. And by giving albuterol, it stimulated this beta 2 receptor. It caused that bronchodilation, and it as well would help lower that serum potassium level. Now, there are other treatments to lower serum potassium that are more significant, but that was a second use of that albuterol, was to help lower that potassium as well. So now that we've kind of gone through those 4 receptors, we're going to move into the medications themselves. And so make sure you kind of get those 4 receptors straight in your head: alpha 1, alpha 2, beta 1, and beta 2. Because as we go through these medications now, we're going to talk about how they specifically target certain receptors over others. Some medications will isolate to one of those receptors. Some work on all 4 of those receptors and just different affinity to one receptor versus the other. So it's really important that we have that in the back of our minds. So with that in mind, Tanner, let's just start now with the actual pharmacology. And to start, we want to go through beta blockers. So these are going to be medications that are going to be blocking the beta 1 and the beta 2 receptors that I just talked about.
Right. And beta blockers will be used to, one, decrease the strain on the heart because we're decreasing heart rate and contractility. So that's going to lower the oxygen demand of the heart tissue. So as a result, beta blockers are typically used in patients with coronary artery disease. You'll see this often with our congestive heart failure patients as well, hypertensive patients. You can have medications that are going to block beta 1 and beta 2. They can be selective for beta 1 or non-selective, meaning that they'll block both beta 1 and beta 2. So just real basic, remember that they typically end in the suffix lol. So labetalol, metoprolol, carvedilol, you get it here. This is what, typically you think of when you hear the beta blockers. Little trick when you're trying to remember if it's going to be selective or non-selective. So if it starts with a letter from the first half of the alphabet, then it is going to be beta 1 selective. Second half of the alphabet is non-selective. Your exceptions to this is metoprolol and carvedilol. So metoprolol is a beta 1 selective and carvedilol is a non-selective. But if it's from the first half of the alphabet, then remember it's going to be beta 1 selective. So atenolol is a beta 1 blocker. Again, your 2 exceptions, metoprolol and carvedilol. Again, if you think first half and second half of the alphabet, kind of just is a cheap trick to keep these straight in your mind. A couple quick examples of these. So propranolol, sotanolol, timolol, those are going to be your non-selective examples. Remember that these drugs will act on beta 2 receptors as well. So you can have some bronchoconstriction. Be very careful when using these with patients that have asthma. Beta 1 cardioselective drugs, so that will be metoprolol, esmolol, atenolol, et cetera. Those are going to be some examples of your beta 1 selective. And these might be a better choice for you, especially with these asthmatic patients, because you're not going to have the beta 2 involvement. And so you're not going to see the bronchoconstriction there. Remember that labetalol and carvedilol will both have alpha and beta blocking effects. So by also blocking alpha 1 receptors, these drugs will cause some vasodilation, and that is helpful because that will reduce the afterload on the heart. Remember when we talked about the alpha 1 receptor earlier in this discussion, we were talking about how that was going to increase your SVR. And so by blocking your alpha 1 receptors, you're going to have a decreased afterload and then a decreased demand on the heart.
Yeah, and it's very important to understand the difference between that cardioselective and the non-selective, exactly for what Tanner said with that bronchoconstriction. So if you think about it, beta 2 being stimulated is usually going to cause our bronchodilation. So that's why we have to be very mindful when we're going to select one of these drugs. If you do give one that has that non-selective property, you are going to inhibit that bronchodilation. So you are going to cause that bronchoconstriction. So I feel like very typically, we intraoperatively stick more to the beta 1 cardioselective drugs, but we also see a lot of patients on the betalol and carvedilol as well, which affect both the alpha and the beta blocking effects. And so you just have to keep that in mind, which type of medication here you're using, whether it's cardioselective or not. A nice thing about esmolol It's one of the drugs that I see often used intraoperatively. It's very fast on, very fast off because it's metabolized by plasma esterases. And so it can be used very effectively for refractory tachycardia, such as atrial fib patients. And more adverse effects from a generic standpoint of all beta blockers are going to obviously be bradycardia. That's something that we're trying to do, but again, you can overshoot and cause too much bradycardia, which will also result in hypotensiveness, fatigue, dizziness, and constipation. So these are all things to just be mindful of when you're giving beta blockers to patients. Now, I kind of alluded to this, but if you give too much, obviously we're going to get the patient to be more on the bradycardic side. But what are some more detrimental consequences to overdosing on beta blockers? And so when you overdose on a beta blocker, this is going to result in severe hypotension, severe bradycardia. And if you're using a non-selective beta blocker, it could be severe bronchoconstriction as well. So how do we treat an overdose from beta blockers? Well, we can give glucagon. We can obviously cardiac pace them if we're very bradycardic. We can give isoproterenol, which we'll talk about later, but that's a beta-1 stimulant. So that'll increase that heart rate and just keep that pump moving. You can give calcium to increase the contractility there, and phosphodiesterase 3 inhibitors. And then you can also give epinephrine. And again, we're going to talk about some of these drugs moving forward, but specifically right now, I'll talk about the phosphodiesterase. So phosphodiesterase is the enzyme that breaks down cyclic AMP. So by giving a phosphodiesterase 3 inhibitor, such as milrinone is an example of that, what this will do is it'll mean that you'll have more cyclic AMP remaining in these cells, which will then be able to cause an increased heart rate and contractility. Because remember, phosphodiesterase is the enzyme that breaks down cyclic AMP. So if we're inhibiting that enzyme from working, we're going to keep that cyclic AMP around longer to increase the heart rate and increase that contractility. So if a patient is on, let's say, scheduled beta blockers prior to surgery, typically we'll have them continue their dose all the way up until the procedure. When you need to be mindful about when you shouldn't give beta blockers or when you should give something before you give beta blockers, one of the most, I feel like, common test questions is, what do you do with a patient that has a pheochromocytoma? And the textbook answer here is you do not give a beta blocker to a patient with a pheochromocytoma prior to giving an alpha blocker. Because if you do, you will cause all that epinephrine and norepinephrine to bind to more of the alpha receptors that are available then instead of the beta receptors. Because remember that pheochromocytoma is releasing tons of epinephrine and norepinephrine. So if you are blocking the beta receptors, all of those epinephrine and norepinephrine molecules are now going to go bind to the alpha receptors that are left, which is going to cause a further increase in blood pressure, further vasoconstriction, and a further increase in the afterload on the heart. So you can see how that would be very detrimental if you give a beta blocker first. So first you have to give alpha blockers, and then you can go ahead and give the beta blockers. So that's a big no-no, a big contraindication to giving a beta blocker.
The next class that we want to talk about are alpha antagonists. So these medications can either be alpha 1 blockers, alpha 2 blockers, or you can have some that will block both as well. So a common alpha 1 selective blocker will end in the suffix -osin. So prazosin is an example for this. Selective alpha 1 blockers will cause vasodilation because, again, you are going to be blocking alpha 1. So if alpha 1 is going to be constrictive mainly, and you're going to be increasing SVR, then if we're doing an alpha 1 blocker, then you can track that that's going to be decreasing SVR due to vasodilation. Many times you can see patients with BPH on these medications. You can also have alpha 2 selective antagonist. So remember that alpha 2 receptors will inhibit their G-coupled protein receptors. So GI inhibitory, you're going to have alpha 2 receptors that are going to be inhibited. So now, if an alpha 2 receptor typically inhibits the release of norepinephrine when they are stimulated, if we are blocking alpha 2, then there will be more release of norepinephrine. And so this will cause an increased blood pressure, increased heart rate, because you have more of the norepinephrine that's going to be going across that synaptic cleft. Phenoxybenzamine is a non-competitive antagonist of both alpha 1 and alpha 2. So by blocking alpha 1, this will result in vasodilation. Remember that because alpha 2 is also blocked, that there is going to be more norepinephrine that is being released. And so since we have alpha 1 receptors that are blocked, we don't really see a compensatory vasoconstriction. But you should keep in mind that norepinephrine will cause an increase in heart rate because you're still going to have that norepinephrine binding to the beta 1 receptors. And so you'll see still some heart rate changes. Just keep in mind that you don't see the effects of norepinephrine regarding vasoconstriction simply because we have those alpha 1 receptors blocked. Like Cole mentioned, when we're talking about pheochromocytoma, prazosin, phenoxybenzamine, there's going to be medications that you'll see often here. Remember that, like Cole said, you're always going to alpha block before you beta block. These are also another, situation where you could be using these medications. Phentolamine is going to be a competitive antagonist of both alpha 1 and alpha 2. So it's similar to phenoxybenzamine and will cause some vasodilation. Remember, because we're blocking there the alpha 1, and then you can still see that tachycardia because we're also blocking the alpha 2, and that norepinephrine is going to be binding to that beta 1.
All right, I know this is a lot of information, so hopefully you're still tracking with us. We're going to keep cruising right along here, and we're going to jump now into inotropic agents and catecholamines. So the first and most popular one, I feel like, is epinephrine. So epinephrine is an agonist at beta 1, beta 2, alpha 1, and alpha 2 receptors. So it covers all four of the ones that we talked about at the beginning of this talk. And as a result, effects are going to include bronchodilation due to the beta 2 being stimulated. You're going to have an increase in heart rate due to the beta 1 stimulation. And you're going to have an increase in SVR and blood pressure due to the alpha 1 stimulation. Now, the alpha 2 and the beta 2 stimulation does slightly inhibit the total amount of vasoconstriction that we see from that alpha 1 stimulation. And that's because, if you remember, the beta 2 and alpha 2 will both cause some sort of vasodilation effects. But overall, the epinephrine is going to cause a bigger vasoconstriction effect from having a higher affinity for that alpha 1 receptor. Now, depending on the dose that you're running epinephrine at will depend on which receptors it has a higher affinity to. And at lower doses, epinephrine favors more of the beta receptors. And then as the dose increases, it switches to favor the alpha receptors. And then again, so by stimulating all of these at the same time, some of the effects are going to contradict each other. So it's important to give medications that can target and isolate certain receptors. Epinephrine is a great medication to give in rescue situations, emergency situations where you really got to get that pressure up quickly. If you really got to cause some bronchodilation, maybe you have a bronchospasm. I've seen epinephrine used a lot as well. It's a great rescue drug, but again, it stimulates all of these receptors. So there are other medications that can be used that'll target certain receptors versus others for certain situations where you'd want to do that. But before we move on to some of those medications, I just want to give the warning to be cautious with epinephrine when given to pregnant patients, and due to being considered a category C medication. And additionally, epinephrine is a tocolysis effects, which is, again, due to that beta 2 stimulation, which is going to combat the action of Pitocin. So again, you wouldn't want to be given this in a laboring patient. And again, if a emergency situation arises here and you're doing this as a rescue drug, I mean, that's just, it is what it is. But again, this is something where if you're trying to boost someone's pressure, epinephrine is probably not going to be your number one drug to be giving in a laboring patient, or again, in a pregnant patient as well. Now, norepinephrine is a natural catecholamine, and it is going to stimulate alpha 1 and alpha 2 with a little bit of beta 1 stimulation as well. So again, not a lot of beta 2 at all, just more alpha 1, alpha 2, and some beta 1. So we're eliminating that beta 2 receptor that we were stimulating with the epinephrine when we go now to norepinephrine. So at lower doses, similar to the epinephrine, the norepinephrine is going to favor the beta 1 receptor, which will increase the heart rate and contractility. Then as you increase the dose of norepinephrine, there's going to be more alpha 1 and alpha 2 stimulation. So there will be an increase in that vasoconstriction effect, which is then going to hinder the amount of total increase in heart rate because of that baroreceptor reflex. So as now you're causing more constriction in the vasculature, you're going to cause that baroreceptor reflex to kind of lower the heart rate a little bit. But again, you're stimulating that beta 1 receptor. So overall, you will still see an increase in heart rate. Now, norepinephrine is used in most shock states. It's a limited, and it's except for the cardiogenic shock, because in cardiogenic shock, you don't want to increase the afterload with that alpha 1 stimulation. But otherwise, for most other shock states, norepinephrine is one of the first line drugs that we would use. And again, be careful about infusing this through a smaller peripheral IV, because if the IV does infiltrate, it can cause necrosis to that local tissue just from the extreme vasoconstriction that it would cause to all the small vasculature in that area. And then also with giving this drug, blood flow is going to decrease to the pulmonary, the renal, and the mesenteric organs as you're doing this long term. So this is especially more in the ICU patients where they're going to be on norepinephrine drips for several days at a time. It's going to constrict the vasculature to those organs, which will then has some long lasting effects as you continually give that infusion. And so this is again why, especially when I used to work in the ICU, you'd be really monitoring renal status, et cetera, with these patients on long term infusions of norepinephrine, just to make sure that they were still perfusing to their kidneys.
Next one we want to talk about is dopamine. And Cole, you just mentioned, checking renal status, checking the kidneys. This is known to be a renal protector because at lower doses, it will cause renal vasodilation and increase blood flow to the kidneys compared to the other pressors that we're talking about here. This is something that is debated as if this is actually, beneficial. The urine output does increase. It's shown that long-term morbidity and mortality, however, stay the same. And so again, this is, the renal protection, quote unquote, is pretty heavily debated. It is something to mention here, though. We talked about at different doses, you can see different things here with dopamine. So remember that at the lower doses, so 1 to 2 mics per kilogram per minute, dopamine is going to stimulate the dopamine 1 receptors. This is what's going to cause that vasodilation. As your dosage increases, you're going to be increasingly involving the beta receptors. And so at 5 to 10 mics per kilogram per minute, you'll see some more beta involvement. With higher doses than that, so greater than 10 mics per kilogram per minute, you're going to see some alpha receptors being stimulated as well. So there's several different ways that dopamine is going to be working. In addition to the alpha and beta receptors, there's several different types of dopamine receptors in our body, which are G protein coupled receptors. So you have those in your coronaries, you have them in your renal and mesenteric areas as well. You also have dopamine receptors in the brain. We know that. So again, dopamine is going to be acting in various different places. And then you should also keep in mind that depending on the dosage is also going to be indicative if we're stimulating the dopamine receptors strictly or if we're moving into beta or even alpha stimulation as well. Now let's move into synthetic catecholamines. And so the first one we want to talk about here, Cole already briefly touched on this earlier in the discussion, but isoproterenol. This is going to stimulate beta 1 and beta 2 receptors. So you'll see an increased heart rate, you'll see increased contractility, and you'll also see some bronchodilation. Remember that you're getting that beta 2 stimulation as well. So often you'll see this with heart transplant patients because remember that their hearts are denervated, and so they will be unresponsive to trying to manipulate the SA node. So if you're trying to give atropine, this is going to be totally ineffective for patients that have a heart transplant. And so isoproterenol is going to be the medication of choice when you're trying to really change the increased heart rate there with these patients. Heart transplant patients, I should also mention, have a depleted or even absent catecholamines. And so again, this is another reason that isoproterenol is going to be very appropriate for these patients. It can act as a chemical pacemaker for the heart. A lot of times you'll see this in cath lab. They'll be using this towards the end of case typically. This is when you turn your gas off, right? When they turn the isoproterenol on, you turn your gas off, you're about to wake up. So yeah, but this is oftentimes what they use to use basically as the pacemaker there for the heart. Think about also with patients that have coronary artery disease, you're going to want to, be very cautious with this because you're going to see increased stress. And then because of that increased stress, you're going to see increased oxygen consumption with your myocardial tissue. And then you're also going to see a drop in your diastolic blood pressure because you have that beta 2 stimulation. So that's what's going to cause that vasodilation. So as a result, your coronaries could see less coronary artery perfusion because of the decrease in the diastolic blood pressure, and then you also have increased oxygen demand because you have that more stress that's being placed on the heart. So if you have someone who has coronary artery disease, isoproterenol should be used very judiciously. This is not something that really is a great fix for them. Typically, you will only see this to treat significantly a heart block. And again, we see this with, heart transplant patients that are unresponsive to atropine. If another patient, for whatever reason, had this, the same clinical picture where they were unresponsive to atropine, then you could move here to isoproterenol as well.
So now let's move into two of the more common pressures that we give intraoperatively, and that's going to be phenylephrine and ephedrine. So phenylephrine is specific for alpha-1. And this is great because it's going to cause an increased blood pressure due to increasing the SVR. And then it's going to cause a baroreceptor reflex that will lower the heart rate. So we want to give this specifically in patients or situations where you are targeting the idea of wanting an increased afterload, but then a lower heart rate. So like, especially after you've maybe given a neuraxial blockade to somebody. So you just done a spinal anesthetic, and we want to make sure that we're continually keeping that afterload high. This is a great drug that we would give. We'd give phenylephrine in this situation. Whereas ephedrine acts a little bit differently. So ephedrine acts both directly and indirectly by stimulating both alpha and beta receptors. So when you give ephedrine IV or IM or however you give it, it's going to, first of all, directly stimulate those alpha and beta receptors. But then it's also going to stimulate the body to release more of those natural stores of catecholamines that are then going to bind to the receptors. So that's the indirect effect that it has. So as a result, it's going to increase the SVR from that alpha-1 stimulation, just like the phenylephrine will or the NEO will. But in addition to that, it's going to also increase the heart rate because now you are also stimulating the beta-1 receptor, and you're causing that increase in heart rate as well. So this is nice to give in patients, especially that are hypotensive during surgery, that also are bradycardic. So if you have somebody that you think if they have an increased heart rate will also help with their blood pressure, then you can give ephedrine in this situation. I know a lot of anesthetists will give phenylephrine to people that are bradycardic, and they'll also maybe give some Robenal to increase the heart rate with that as well. So you can kind of do both sides there, but just know the biggest difference here is phenylephrine will have that baroreceptor reflex to lower the heart rate, whereas ephedrine should increase the heart rate while increasing the blood pressure as well. There's often been a debate in OB anesthesia about what is better to use, phenylephrine or ephedrine, as the first line to treat the spinal or epidural results in OB anesthesia. And because when we give these blockades, both spinal and epidural, you're going to have this drop in blood pressure. And so in the past, it's really always been thought that ephedrine would be the better choice of the two to increase the uterine blood flow compared to phenylephrine, because we want to make sure we're getting enough blood flow to the baby. However, recent studies have now come out showing that ephedrine actually produces an increased fetal metabolic rate, which then leads to more fetal acidosis upon delivery. So fetal acidosis is basically that picture of having less oxygen, if you will, than compared to the phenylephrine. So studies are actually showing now that the fetal pH balance when the baby comes out is actually better with phenylephrine compared to ephedrine. But again, with ephedrine here, because it stimulates that release of natural catecholamines, it's not going to work as well in septic patients or heart transplant patients. And this is something that I never gave in the ICU. I don't know about you, Tanner, if you ever gave ephedrine in the ICU, but I honestly did not even know about ephedrine until I entered anesthesia school. Again, I think it's just because in a lot of the septic patients that I dealt with, septic shock patients, cardiac sick patients, et cetera, there was just that decreased amount of natural catecholamines, and we never really gave ephedrine because it was not going to work quite as well in those patients. And lastly, with ephedrine is it can cause tachyphylaxis as well, which is where subsequent doses are going to have a less response. And this is due to those catecholamine stores becoming depleted. So if you give a round of ephedrine, it's going to indirectly stimulate that release of catecholamines, and maybe it'll last for a few minutes and their blood pressure starts to sag back down. And so you decide to give more ephedrine, and it may not have quite as great of a response as it did the first time because you've now used some of those natural stores up already.
When I was in school, I had a preceptor ask me what that was called when ephedrine is having less and less of an effect. And I was like, I cannot remember. I explained like why it was happening. I just could not think of tachyphylaxis. And then all day they just kept asking, think of it yet? Think of it yet? And then finally at the very end of the day, they said it. And I was like, oh, word. I feel like we had just actually gone over that in school or something like that. But I will never forget that term from there on out. Thank you, preceptor, who will not be named, but it's burned in my brain. The next one that we should discuss here is going to be vasopressin. Vasopressin is naturally made in the hypothalamus. You have it stored in your posterior pituitary gland. This will cause vasoconstriction because of vasopressin 1 receptors. Vasopressin 2 receptors will cause water to be reabsorbed in the collecting ducts of the kidney. So you're going to have basically a two-factor mechanism here, where one, you're going to have increased fluid retention, and then two, you're going to have direct vasoconstriction because of that vasopressin 1 receptor. This is unique because you have vasoconstriction while you also selectively have dilation of the afferent renal arterioles as well as the pulmonary and cerebral arterioles as well. So this is something that is unique here with vasopressin. Often vasopressin is going to be a second or third line vasoconstrictor. You can also use these for first line if the patient's on an ACE inhibitor or on an ARB or an angiotensin receptor blocker as well. So keep that in mind. That's often something that comes up if the patient is on an ACE inhibitor or an ARB, that vasopressin is going to be your go-to. Dobutamine. Dobutamine is a beta agonist that causes increased heart rate, increases your contractility as well. This is really good for cardiogenic shock patients because you are helping the heart pump. So you have that increased contractility. You'll see this a lot of times with open heart procedures and post bypass where you're using dobutamine again here for the increased heart rate, but then also mainly there for that increased contractility.
So now let's go into selective beta 2 agonists. So these are going to be medications that target just the beta 2 and not the beta 1 receptor. So a great example of this, as I mentioned earlier in the talk, is going to be albuterol. And the main effect from stimulating beta 2 that we want to see typically is bronchodilation. So we often give beta 2 agonists in patients where we're trying to dilate those bronchioles, open up the airways, etc. This is going to have a limited effect on the heart rate. So that's why we want to give these meds compared to just beta agonists that are going to stimulate both beta 1 and beta 2. Is we want to get rid of the cardiac effects and just focus here on the effects at the lungs. But as you remember that I said earlier in this talk, there are other effects that beta 2 stimulation is going to have. And so one of those was a decreased potassium level. So keep in mind, by giving these medications, if you already have a patient that's borderline low on their potassium, this is going to drop that even further. And because you have beta 2 receptors in the vasculature, remember that causes vasodilation. So you actually will see a little bit of vasodilation and a drop in blood pressure there as well. And then additionally, an increase in the glucose and the insulin from these medications. Now, you can give beta 2 agonists to delay premature labor. Because remember, beta 2 stimulation is going to relax the uterus. So if you have a patient that comes in and they're in preterm labor, they're contracting, and you want to try to stall their labor and give the baby more time to develop prior to delivery, then you can give a beta 2 agonist in this case to help relax the uterus and delay that from happening. Now, alpha 2 agonist, as Tanner mentioned earlier, this is going to be Precedex or clonidine are probably two of the more common alpha 2 agonists that we're aware of and that we use in anesthesia pretty frequently. As Tanner mentioned, Precedex is probably one of his favorite drugs to use. They lower blood pressure by inhibiting that norepinephrine release from the neurons and result in that vasodilation effect. And I won't go into it too much here because Tanner really did a great job earlier of kind of talking about that. But the nice thing is we have sedative effects associated with this as well. So that's why we often will give these medications in anesthesia, because they have a sedative effect and they also have an analgesic effect as well. So it's really a nice all-around drug to use. But one of the common cardiac side effects that we'll see from giving these drugs is bradycardia. And so keep in mind that if you're going to be running a patient on a Precedex drip or maybe giving a bolus of Precedex, et cetera, just to be mindful of the fact that there is a bradycardic side effect that can develop from this. So just keep in mind, if you're already going to be having a patient who's bradycardic to start, you might have to just keep an eye on their heart rate.
You guys are doing great. We have antihypertensives and diuretics left, and then we are going to wrap this up. I know this is a lot of material, a lot of content, and we're just moving through it. You're doing great. So the next thing we want to talk about here is the antihypertensives. And the beta blockers are, we've already gone through that. So what we really want to focus on here is the calcium channel blockers. So you have two main groups. You have dihydropyridines and non-dihydropyridines. The difference here we'll get into in just a second. The goal of calcium channel blockers is to cause negative inotropic and chronotropic effects. And so you want to also see coronary and systemic vasodilation. Each calcium channel blocker is going to be specific in its ability to perform one or more of these different actions. Like I said, we're going to talk about the differences here. So the dihydropyridines are going to be more potent vasodilators compared to their effects on the contractility and conduction. So for this reason, this class of calcium channel blockers is used more for hypertensive treatment, and then you have less of this use for antiarrhythmics. This is going to cause a decrease in preload and afterload, which will decrease oxygen consumption on the heart. And ultimately, you're going to have a better cardiac output. Examples of this would be amlodipine, clevapine, which is going to be Clevaprex, beautiful, beautiful drug, and also nifedipine as well. Clevaprex, we often use in anesthesia for as just an IV antihypertensive. It's highly selective for vasculature and has basically no effect on the myocardial contractility or conduction. So again, really, really nice for an antihypertensive drug. Duration is about 5 to 15 minutes. Onset is 2 to 4 minutes. It's very, very fast on, very fast off.
On the flip side, the non-dihydropyridines are going to be used more for cardiac contractility and conduction purposes and less effect on the vasodilation effects. So for this reason, this class of calcium channel blockers is going to be used more for antiarrhythmics and less for actual hypertensive treatment. And so in order to have depolarization through the SA node and the AV nodes, calcium influx has to occur in order for that transition and that depolarization to go through the heart. So if we can block this effect, then in essence, we'll prolong the cycle and cause a negative chronotropic effect. So because the ventricular pacemaker cells, though, are more reliant on sodium influx, calcium channel blockers work better for patients that have that atrial tachyarrhythmia. So anything going through the SA and AV nodes rather than down in the ventricular conduction tissue. So examples of these medications would be verapamil or diltiazem. Again, verapamil is often used 2.5 to 10 milligrams IV. But again, these kind of drugs are going to be more used for those atrial tachyarrhythmias rather than the ventricular ones. And again, we're not really going to use this as much as a hypertensive crisis medication as well. Now, cardiac contractility is also dependent on calcium influx. So again, this is not cardiac conduction, this is contractility. So both of these two things have calcium influx, which is going to be very dependent on the ability of the heart both to conduct and then also to contract. So that's why, in addition to slowing the heart rate, these calcium channel blockers also have a negative inotropic effect. So it's going to decrease the amount of contractility and the strength there of each actual contraction of the heart. So this is going to lead to a decrease in the myocardial oxygen consumption, because if you think about it, if now the tissues are not going to be working near as hard in the myocardium of the heart, it's going to decrease the actual oxygen consumption going on in those myocardial tissues. One side point I do want to mention on calcium channel blockers that we also see used in anesthesia, but differently from a cardiac standpoint, is nimodipine. And that has often been used in neuroanesthesia for cerebral vasospasms. So these cerebral vasospasms are often associated with ruptured aneurysms, often that we see undergoing neurosurgery. So the surgeon may request, or you may see a patient have gotten nimodipine, and the calcium channel blocker specifically here is used to decrease the amount of the cerebral vasospasm that can occur after you've had a ruptured aneurysm. Additionally, now for anti-hypertensives, we want to talk about nitro-vasodilators. So nitric oxide causes smooth muscles in the vasculature to dilate. So if we can give medications that are going to increase the amount of nitric oxide in the body, such as we call these class of medications nitro-vasodilators, then by increasing the amount of nitric oxide in the body, it's going to cause more vasodilation to occur and a drop in blood pressure. So the most common two medications in this class that we often talk about are nitroglycerin or nitroprusside. And they're used mainly to treat angina and myocardial infarctions by primarily improving the coronary blood flow and then inhibiting any coronary vasospasm that can occur. Side effects, though, of giving these medications include headaches from cerebral vasodilation. So again, if we're dilating the vessels in the brain, you're going to cause more blood flow through the brain. More volume is taken up in the brain by that cerebral vasculature, which is going to put more pressure on the rest of the head and gives a headache, which is why caffeine often will decrease a headache then if you have a headache, because it causes vasoconstriction up there. And that's often why in anesthesia, if you have a patient who has maybe a post-dural puncture headache, we often first line, or one of the first lines will give caffeine to patients to help cause that vasoconstriction and decrease that headache. So again, here, same principle. By dilating the vasculature in the cerebral space, nitroglycerin and nitroprusside will cause a headache potentially as well. It can cause cutaneous flushing. It can cause reflex tachycardia. When you have that drop in blood pressure quickly, it'll then have an increase in that heart rate to compensate for that. Now, you need to be careful about giving these medications to patients that are on phosphodiesterase inhibitors, such as Viagra, because Viagra inhibits cyclic GMP degradation, while nitrodilators will stimulate cyclic GMP production. So if you think about it, they're both doing, in essence, the same thing. Viagra is going to inhibit the breakdown of cyclic GMP, whereas nitrodilators stimulate more cyclic GMP. So both sides of that are increasing the total amount of cyclic GMP. So this combination will cause a potentially significant increase in cyclic GMP levels and potentially lead to significant hypotension. So you just need to be aware that if you have a patient on a phosphodiesterase inhibitor, and one of the more common ones being Viagra, you should just be cautious of the dose that you give of these medications. Now, specifically with sodium nitroprusside, it produces both an arterial and a venous relaxation, whereas nitroglycerin has more of an effect on the venous system. So keep that in mind, that if you're targeting just the venous system, nitroglycerin is the one you want to go to. If you're targeting both arterial and venous, then nitroprusside is probably your better option. Now, with nitroprusside specifically, it's used primarily for emergent control of hypertension. It has a very rapid onset within seconds, a very short duration as well, about 1 to 3 minutes long. And because it affects both the venous and arterial side, it's going to decrease both your afterload and your preload, which results in then your left ventricular volumes being decreased and a decrease in the myocardial oxygen consumption because you're not having to work as hard at the heart. Usually you start an infusion of this around 0.3 micrograms per kilogram per minute, and you continue to titrate that up until you get your expected response. One of the main side effects, though, of nitroprusside is cyanide toxicity. Cyanide is produced as the nitroprusside is metabolized. And so the risk of toxicity goes up when the dose is over 2 micrograms per kilogram per minute, due to the body being unable to metabolize the amount of cyanide that's coming from that nitroprusside. It's just coming too quick once you get over that 2 micrograms per kilogram per minute. So that risk goes up there. Signs of cyanide toxicity are going to include tachycardia. You'll also see tachyphylaxis of the nitroprusside. So similar to what we saw with ephedrine, you're going to have a less response from nitroprusside with subsequent doses. There'll be metabolic acidosis and then an increased mixed venous oxygen content. So those are all signs of a potential cyanide toxicity. And we treat this by obviously discontinuing the nitroprusside infusion. Then you then treat your acidosis and administer 100% oxygen as well. Nitroglycerin is used more for treating angina pectoris and ischemia, which is under anesthesia. So typically, if we see these events happen under anesthesia, we're going to do nitroglycerin and not nitroprusside. It has a rapid onset, about 1 to 2 minutes, short duration, about 10 minutes. And again, it has more vasodilation of the venous system, which allows for more blood to pool, if you will, in the veins, and less of it will return to the heart, which will result in a decrease in preload, lower filling pressures, and a decrease in the myocardial oxygen consumption then with each contraction. The larger coronary vessels are going to have vasodilation, which results in more blood flow to the ischemic myocardial tissues as well. Typically, we give sublingual nitroglycerin tablets and then an IV infusion is started. This is more if you have a patient that's undergoing potential heart attack and being brought into the hospital, they'll be giving these sublingual nitroglycerin tablets ahead of time. But obviously, we're not going to be doing that in anesthesia. So under anesthesia, we give IV nitroglycerin first, starting around 10 to 20 micrograms per minute, and then we titrate that up to effect. So in summary, nitroprusside is mainly used to decrease blood pressure, whereas nitroglycerin, while it can be used to control hypertension as well, we often will still give it under anesthesia, but it's mainly used for more of an ischemia purposes rather than the hypertension purposes. And before I switch over to Tanner here to go through diuretics, I do want to quick throw in one more medication that kind of fits into this class, and it's hydralazine. So hydralazine is thought to have the same mechanism of action as nitroglycerin and nitroprusside. And it works primarily by causing arterial relaxation. So it doesn't really have any venous effects. It's mainly in the arterial system. Now, its onset can be anywhere up to 5 to 20 minutes. And so if you're giving this to a patient in a perioperative setting, just be mindful that you might have this delay in onset. So if you have a patient that's hypertensive, you're trying to get it down with hydralazine, just be careful not to give subsequent doses or other antihypertensives too fast, and then the hydralazine kicks in, and now you're kind of trying to play catch up and go back the other way by treating hypotensiveness. Now, the dose is going to be anywhere between 2.5 to 20 milligrams. And again, you can see some tachycardia from that drop in blood pressure as well. It's one of the main side effects that we see. So yeah, I know, again, you guys are doing awesome. We're on to our last part now. The last thing I want to talk about is often hypertensive chronic patients are on diuretics. And so we just want to go through briefly some of the different classes of diuretics that patients can be on. And again, we have a full talk on our renal system about all this. So we're going to keep this pretty high arching right now, but Tanner's just going to go through some of the diuretics.
Now that we're talking about diuretics, we're not going to spend a ton of time here to review the anatomy of the nephron and the renal system. We have an entire episode specifically for the renal discussion, and we talk about the full review of the renal anatomy there. So we're not going to go into crazy in depth here, but we do want to go through specifically the drugs and talk about how these are working in the body and the differences in between these. Well, we often see diuretics included for treatment regimen for hypertension. So we thought that it was important to include them here as we're talking about the different ways that, we're affecting these adrenergic receptors. We also wanted to include the diuretics here as well. First thing I want to talk about is the ACE inhibitors, so angiotensin converting enzyme inhibitors. These are going to inhibit angiotensin converting enzyme, or ACE is what that's known as, which will block angiotensin 1 from converting to angiotensin 2. Angiotensin 2 is going to be a potent vasopressor that stimulates the release of norepinephrine, and you'll also see the release of aldosterone here as well. So blocking angiotensin 2 from being made, again, remember ACE is going to be blocking angiotensin 1 from converting to angiotensin 2. Blocking that is going to result in vasodilation. The drugs that we see here with ACE inhibitors, you will end in pril. So you remember lisinopril, captopril. Those are going to be the pril endings for the ACE inhibitors. Often you can see the adverse side effect of a cough. This is pretty common that you'll see a chronic cough. Is actually one of the main reasons that people will be taken off of ACE inhibitors, and we'll talk about what they could be moved to here in a second. But you can see this chronic cough. Angioedema is another, adverse side effect that you may see. Hyperkalemia, and then ultimately you could see some renal failure. You, like I said, will see the coughing there is kind of the main thing. 25% of patients on these ACE inhibitors will be seeing this. The next class is carbonic anhydrase inhibitors. The main one we think of here is acetazolamide. This is going to be working in the proximal tubule. This is going to block the ability to reabsorb bicarb and secrete hydrogen. This is going to form a systemic metabolic acidosis. This is going to alkalize the urine. So by doing this, we're going to increase respiratory drive. More sodium is going to stay in the filtrate, which is going to draw more water there into the filtrate. This is how you see that diuresis take place. Osmotic diuretics, we think of mannitol, glycerin, are main ones that we think of in here. Sugars that are filtrated but are not reabsorbed like normal. So it keeps the osmotic pull on water to stay in the filtrate. It also will pull water into the systemic serum that can cause increased blood volume. So we give this to patients when we're trying to prevent acute kidney injury. We can also give it to treat intracranial hypertension because, again, it will pull that fluid off the brain. Mannitol is going to increase urine output for pre-renal failure, but it's important to remember it's not going to increase urine there for intrinsic. Loop diuretics, these are extremely common. We think of Lasix here is probably the most common one that we see with the loop diuretics. In the ascending loop of Henry, this is going to be impermeable to water. So the loop diuretics are going to prevent sodium, potassium, and chloride absorption, which will keep water in the tubule further down the line. So this is how this is, again, going to be affecting that diuresis. You're going to see this given for pulmonary edema. If someone has acute kidney injury, you can also see this given also for someone with CHF. This is typically a very common medication that's going to be given to them. It can cause ototoxicity, and then you can also see some hypokalemia. This is actually, something that is very common when you're giving loop diuretics. We think of potassium sparing diuretics versus non-potassium sparing. This is going to be non-potassium sparing, so you can see the hypokalemia. Thiazide diuretics, main one here is hydrochlorothiazide. This is going to inhibit the sodium chloride co-transporter in the distal tubule. This will, in turn, activate the sodium calcium antiporter. So that will cause the absorption, or the reabsorption, I should say, of calcium. You can see this again for hypertension. You can see this with the heart failure patients. You can also see this with osteoporosis because, again, you're going to see that reabsorption of calcium. Side effects for this, you can see hyperglycemia, and then you can also see some hypercalcemia as well. That totally makes sense. Potassium sparing, I mentioned earlier when we were talking about the loop diuretics, that we'll see hypokalemia. For potassium sparing diuretics, we typically think of spironolactone. This will inhibit potassium secretion and sodium reabsorption in the collecting ducts. So spironolactone antagonizes aldosterone and inhibits potassium excretion and the sodium reabsorption. Aldosterone is released from the adrenal cortex and will be acting on the distal tubule to reabsorb sodium and water while excreting potassium. So again, this is going to be antagonized by the spironolactone. Last one we want to talk about here is ANP, atrial natriuretic peptide. This is actually made by myocardium in response to atrial distension, and this will cause the sodium and water excretion in the collecting ducts, and this will also inhibit renin. So when you see that you have atrial distension, your body's thinking fluid overload. This is what stimulates that sodium and water excretion in the collecting ducts, and so that's where ANP will be working for that diuresis picture. Again, we're not talking, obviously about the adrenergic receptors here specifically when we're talking about these different diuretics, but when we're talking about decreasing blood pressure and medications that are used oftentimes in these cardiac patients, we thought it was important that we included them here. That was a real fast rundown over the differences between the different diuretics. Some of the side effects that you'll see with potassium, or the potassium sparing, or potentially might want to use like osmotic diuretics when you have intracranial hypertension, or you have different reasons for giving these different diuretics. So important to know why they're working, the differences between them, and we thought it was important to include on this discussion as well. Hopefully, overall, this was a good discussion for you to kind of recalibrate and re-go over all of the different receptors and why these medications are working. Again, many of these medications are ones that we use every single day in the OR, and it's important that we know the why behind the what we're doing, and a good refresher, I trust, for you as we go over these cardiac medications.